Thank you, sir. Thank you very much. Now I would like to invite TOAR LALISANG from Indonesia. Sir is a digestive surgeon. He is currently working at Digestive Surgery Division, Department of Surgery, Septo Magun Kusumo General Hospital. And we have other chairperson, Dr. SACHIN JHAWAR. Dr. SACHIN JHAWAR is currently is the Director Apex Hospital Group of Hospitals, Jaipur. He did his MBBS from SMS Medical College and MS from SMS Medical College, and then he did his MRCS from Edinburgh. Welcome, sir.
Thank you, Vinay, and we would like to invite Dr. Osman from Ankara to start his very interesting deliberation on what to do when you encounter a difficult gallbladder. And from pre-operative phase, now we are entering into the operation theater. And I hope you all have a good insight to what Dr. Osman needs to say.
Thank you very much for this kind introduction. And I would like to also thank Professor Kapoor and my colleagues in India for their invitation. I have already sent my video. Can you play the video, please? Then we'll have the discussion at the end of my video.
Yes, we will play the video and then we will invite you for the live interaction. Please play the video. No, it is already there. Dr. Osman, there is some technical hitch here. Would you like to make the presentation live?
Yes.
Okay, please carry on.
Let me share my screen.
Your screen is visible, sir. If you can do full screen, it will be even better.
Okay. May I start?
Yes, please.
Okay. My topic is okay. My topic is how to handle an unexpected difficult gallbladder found at laparoscopy. This is my disclosure. Let me start my presentation with definition.
I think slides are not moving. Can you make it a slide view? Can we have the other vision plus the other screen? It's not visible. Can you have full slide?
No, Dr. Ajay, the slide is visible. The first slide is visible to us.
Yeah, but he is going on to the second slide, which actually is not moved.
Osman sir, can you go to the next slide?
Next slide, please. Can you go to slideshow, please? That will make the things.
Yes, I am. Let me stop my share. Can you see my slides? No?
We can see only your first slide. Can you move to the second slide? That will make it more clear.
Actually, I am moving, but
it is not moving on the screen, I think.
Sir, you click on the second slide here.
Dr. Osman, if you could stop sharing and share again, sometimes that works.
Okay, let me do it again.
Yes.
Dr. Ajay, do we have Dr. Usman's presentation? If we can do it from here.
Yeah, we're just trying. Actually, he had sent it, but I think it's not opening up in the presentation over here. So we're just trying that. Yeah, we could get it, I think. Yes. Okay. Dr. Usman, we'll play the video now.
You
Is that
play the-
okay?
Yeah, please. There is a technical problem. Okay, I will be happy.
It's so nice. Wonderful. So we can play the video now. Can we start?
Yes, please.
Okay, he's saying, our audiovisual person is saying that I think your video they are able to see now on the screen. So can you again share this slide share? Okay, now we are able to see your slide. Oh, it's again gone. Can you again show, Dr. Usman? Yes, we are able to see your slides now. You can continue.
But I cannot move my slides. You cannot see my movements. Let me stop once more. Can you play my video?
Can we just request? Is it possible?
Can you operate this slide? This
We were just trying to do.
make a slideshow. Just use this one, this presentation. Try to move. Yeah. Oh, it is not. Yeah. No need to go to slideshow.
I do, but it's not working for some reason. I don't know why.
Try to the next slide, please. Second.
Just click to the next slide, please.
Click
Click onto the next slide on the left side. Yeah, below this.
below.
Yeah, below this, the next one. Go down. Yes.
Oh, yeah.
It is there. So you may just show it like that only. That will work. Yeah. The same way you can just click with the.
Let me try once more. Just a second. No. Can you see my slides now? No.
You can see your first slide only. You can.
Oh.
Anyway, not an issue. Not an issue. You can just show it.
Yeah, Dr. Osman, in the same view as you were showing earlier, just keep on clicking on the next slide because we were able to see it. So that is fine. Even if it is not a full slideshow, that is fine.
Okay. Okay.
Yes, that is good. Now, yes, if you click on the second slide, please. Yes. Yeah, please carry on, please.
Okay.
Ah,
It's gone. I will try once more.
Yes, we can see your disclosure slide now. If you click on the next button. Yes, yes.
okay.
That's good.
Okay, let me try once more. Okay.
Yes, please carry on.
Okay. Let me start my talk with the definition of unexpected difficult gallbladder. Unexpected difficult gallbladder is a scenario in which cholecystectomy incurs an increased surgical risk compared with standard cholecystectomy. Cholecystectomy can be classified as difficult in conditions that obscure either the normal biliary anatomy or operative exposure. There are some very well-known risk factors for difficult gallbladder, including old age, male gender, acute cholecystitis, morbid obesity, contracted gallbladder, Meniere's syndrome, chronic liver disease, and finally, prior upper abdominal surgery. I think an important question is, can we predict difficult cholecystectomy? The answer is yes or no. In my institution, we analyzed more than 1,300 patients. And in this study, we analyzed 31 variables to predict difficult cholecystectomy. And in this series, conversion rate to open surgery was 7.7%. And in this study, we analyzed certain risk factors, and you see some of these factors in this slide. And we found that finally, old age, male gender, previous cholecystectomy treatment, abdominal surgery, previous abdominal surgery, and elevated alkaline phosphatase levels were found to be significant risk factors for difficult cholecystectomy. What about the clues for difficult cholecystectomy at laparoscopy? There are some signs of difficult cholecystectomy before surgery, but what about the scenario at the operating theater? At surgery, if anatomy is confusing, or if there is a lack of progression with dissection, let's say in 20 minutes, if there is no further dissection, or unexplained bleeding, or bile leak, and finally, the need of excessive number of clips. Usually more than 4 clips means excessive clips in laparoscopic cholecystectomy. These are signs for difficult cholecystectomy at laparoscopy. And in this scenario, in these cases, I strongly suggest to call a colleague for help in the operating theater. In my country, on behalf of Turkish HPB Surgery Association, 17 expert surgeons and endoscopists came together, and we published a paper, Prevention and Acute Management of Biliary Injuries During Laparoscopic Cholecystectomy. And we conclude this paper as an expert consensus statement. And the rest of my talk will be based on this expert consensus statement. The first statement that I would like to share is the liberal use of intraoperative cholangiography. Here on the left side, you see an intraoperative cholangiography of a laparoscopic cholecystectomy case. In this case, we have noticed a bile leak in the gallbladder bed, and we did an intraoperative cholangiogram. The white arrow shows the cholangiography catheter, and the yellow arrow shows the injury site. In this case, we have noticed that the injury is in the right hepatic duct, and the cholangiography shows that the biliary anatomy is intact. And in this case, we put a T-tube in and completed the surgery laparoscopically. And on the right-hand side, you see the T-tube cholangiography obtained few days after surgery. The T-tube is in the right hepatic duct, and there is a nice passage of contrast into the duodenum, and the anatomy is clear. So if there is a duct in difficult cases, especially in the case of bile leak, we strongly suggest to use intraoperative cholangiography. What's the danger in difficult cases? I think the great danger is overconfidence. Let me share a video with you. This is a case of acute cholecystitis. You see that there is an edema, and there are a lot of blood around, which may show a difficult case. Now the surgeon is trying to dissect a structure, and he thinks that this is the cystic duct. He encircles this structure, and now he's using hammer clips. He placed 2 clips on the common bile duct side and one the other side. And now he's using an energy device, which we do not recommend. And unfortunately, he is also a bile leak. It's a very unfortunate complication, very dismal complication. Now he is irrigating, and now sure that there is a bile leak. This is the problem in difficult cholecystectomies, and one should do everything to avoid this dismal complication. So what are the options in this case? One option is conversion to open cholecystectomy. I think open cholecystectomy is a good option, especially to control bleeding. But in many cases, just conversion to open cholecystectomy may not be useful. In these cases, what are our options? One option is, although many surgeons won't do, or they don't like this option very much, just consider to stop the operation and put a drain in and refer the patient. And the second option is subtotal cholecystectomy. In our expert consensus statement, we grouped the patients into 2 according to difficult gallbladder. If critical view of safety cannot be achieved, the first group is the anatomy is clear, but the inflammation is severe, as in the patient I showed the video. In these cases, we suggest subtotal cholecystectomy. And the second option is open cholecystectomy. But if anatomy is complicated, we are not sure about the anatomy. We don't know where is the cystic duct. We don't know where is the common bile duct. In these cases, subtotal cholecystectomy is not the treatment of choice. In these cases, we recommend open cholecystectomy. So the decision depends on the anatomy. Clear anatomy, subtotal cholecystectomy, anatomy complicated, open cholecystectomy. And actually, this depends on the experience of the team and expertise of the surgeon. Now, I would like to share another video with you. This is a case of severe acute cholecystitis. There are some adhesions between abdominal omentum and gallbladder. I think this is a closed perforation. There is necrosis of the gallbladder. This is really a difficult and challenging case. The surgeon is trying to dissect the gallbladder, but there are firm adhesions and also bleeding around. So in this case, it's not easy to see the critical view of safety, and subtotal cholecystectomy is the treatment of choice. Now the surgeon is removing the anterior part of the gallbladder. And on the right-hand side, you see the lumen. A part of the gallbladder is excised, and the stones are taken out, and the drain is placed, and the surgery is completed. Subtotal cholecystectomy is a life-saving procedure in difficult cholecystectomies. What about anatomical variations? We published a case of acute cholecystitis in a double gallbladder years ago, and believe that surgeons should be aware about possible anatomical variations. They are rare, but please notice that there may be some variations which may render the case not to be operated laparoscopically. In these cases, we suggest open surgery. In surgery, we always tell our residents that there is no easy case. Easy cholecystectomy may be very difficult. This is an example from one of my patients. This patient has a chronic cholecystitis, not very severe chronic cholecystitis. I think you can say that this is a long cystic duct. There is no much inflammation. This may be a straightforward case, but no. Now I am trying to encircle the cystic duct. I am about to done. You can see the tip of the sector. But when we reach the critical wave of safety, this is not the cystic duct. This is the common bile duct. Actually, this patient has a very short cystic duct, and if you cannot expose the wave of critical view of safety, you can injure the bile duct in this patient. And the last topic that I would like to talk on is Miritsi syndrome. What to do? As you all very well know, Miritsi syndrome is an inflammatory phenomenon secondary to a pressure ulcer caused by an impacted gallstone at the gallbladder infundibulum. In some cases, preoperative diagnosis may be possible, but in the majority of cases, this may not be possible. Here you see an MRI scan of one of our patients with Miritsi syndrome. The yellow arrow shows the round stone, and the common bile duct is obstructed. Can we manage these patients laparoscopically? If you have enough experience, yes. Laparoscopic management may be safe and feasible in experienced centers. But personally, I recommend laparotomy for complicated cases. Miritsi syndrome first classified by Professor Miritsi in 1940s, and there are different classification systems. According to one classification system, they may be divided into 5. I will not go in detail, but basically this classification is based on the involvement degree of common bile duct. And type 5 is both cholecystoenteric and cholecystocolodical fistula. Now I would like to present one of my cases with type 5 Miritsi syndrome. Actually, I did this case as open surgery. We couldn't do it laparoscopically. On the left-hand side, you see the cholecystoduodenal fistula. It's shown as with a yellow arrow. There's a fistula between gallbladder fundus and post-pyloric duodenum. We take down this fistula and repair the duodenum. And then, after opening the wall of gallbladder, please now concentrate on the right-hand side. We saw a huge fistula. It was about 3 centimeters in diameter between gallbladder and colodocus. And in this case, we placed a T-tube and repaired the gallbladder wall using as a flap. And this is the T-tube cholangiography obtained on day 4. You see nice anatomy, no leak. There is a gallbladder remnant which we created during surgery, and this patient made an uneventful recovery. Dear friends, dear colleagues, biliary or vascular injuries during cholecystectomy are not perception errors. Years ago, while talking on difficult gallbladder and bile duct injuries, we were considering these injuries as misinterpretation. Duck as in duck or rabbit problem. Are these the ears of rabbit or the beaks of duck? Today, this is not a misinterpretation problem. If you can achieve the critical view of safety, and if you can expose the anatomy, I think the injury rate can be decreased significantly. I would like to conclude my talk with my conclusion slide. Detailed and meticulous preoperative evaluation is critical in all the cases. There is no easy case or difficult case. I think we should consider all the cases as difficult cholecystectomy. And if we do not have enough experience, the best way is avoiding complex cases. And during surgery, if we encounter with a difficult case, the best strategy is invite a colleague. This colleague may be your peer or a professor, it doesn't matter. Second opinion is always good. And finally, surgeons should adjust surgical techniques in the setting of non-routine cases. And subtotal cholecystectomy should be in the toolkit of all the surgeons dealing with cholecystectomy. Thank you again. As I thought that this presentation will be on video, there is a delay to start the presentation. Sorry about that. And I am ready to take questions and for discussions. Thank you very much.
Excellent, Dr. Osman. Despite all the delay, there was good insight into it. And so when do you think a decision to do a subtotal cholecystectomy should be done? Is there any objective criteria you think one needs to follow?
I think there is no objective criteria. The criteria may change according to the experience of the surgeon. As an example, years ago, when I encounter a difficult case or inflammation, my first option was open cholecystectomy. But after getting experience, now I am rarely opening the patients and doing subtotal cholecystectomy. Subtotal cholecystectomy is technically easy and difficult. It's easy if you can clearly see the anatomy, and if you can control bleeding coming from the gallbladder wall. You know, there is a lot of edema, hyperemia, congestion, and if you are in trouble with controlling bleeding, I mean, you may be in a problem. So it depends on your expertise. But instead of opening the case, I suggest subtotal cholecystectomy. It's easier compared to open cases. You know, there are many studies recently regarding the experience of young surgeons for open cholecystectomy. For the young generation, open cholecystectomy is more difficult compared to laparoscopic cholecystectomy.
Absolutely.
So I suggest to do subtotal cholecystectomy instead of opening the patient.
Dr. Ajay, can we have a few questions? Do we have time?
I think we are running out of time. We can have one question if any, we are already out of time. Any one question?
Or I can, I'm LALISANG from Indonesia. I'd like to make a comment to Professor Osman. Is it possible?
Yes, please.
Yes, Professor Osman, it's very nice presentation. But according to me, what is your comment? Because you mentioned if you have some problem with during the lap chole, you just make a conversion or to make the reconstruction or the repair. But according to me, laparotomy is not a guarantee that you get a good view, because laparoscopic itself, with nowadays, and also the technique, the expert for minimal for laparoscopy at the repair or to overcome the bile duct injury by laparoscopic also. What is your comment? Because like I mentioned, laparotomy have also some disadvantages with the view, especially in the region in the cholecystectomy. You know, you understand my my opinion about the view. If you use the laparoscopic, you can change the camera. You can get more vision about the condition of the anatomy. Thank you.
Thank you very much for your excellent comments. I agree with you. Actually, I have the same opinion. Open surgery is not a complete solution. I mean, if you have a difficulty in laparoscopy, you'll have the same difficulty in the open case also. So I don't suggest open surgery in the first line, but if you cannot control the bleeding laparoscopically, in this case, I suggest opening. Or if you are not sure about the anatomy, remember my case with double gallbladder. In this case, I think it's a real adventure to do it laparoscopically. There are certain cases like bleeding or unclear anatomy. You may need to do an open surgery. Otherwise, I completely agree with you.
Thank you.
It was a very good presentation, Dr. Osman. Just want to add some remarks on what you have said, very beautiful lines, which I think everybody who is in the session would also agree that danger is always of overconfidence.
Yeah.
I think that is a very, very valid point. And I would like to add to it, the safest thing is to worry. Keep on worrying to avoid a wrong. Wrong should not happen. That should be in your mind. Second important line was, nothing is easy in lap chole. I think that is the take-home message for everybody. Nothing is easy in lap chole. And Dr. Kapoor always says, most accidents happen on an empty and a straight road. More simple it appears, more accident happens. So I think I would add these 2 points. And now third thing, again, I'm quoting Dr. Kapoor, that you told always a colleague to be called is always helpful. And Dr. Sadiq has also included in his session, and Dr. Kapoor always says that it is called, he calls it as a collegocholecystectomy. So if a colleague comes, he can tell you whether you are close to CBD or not, or you are safe or not. A new colleague joining the operation theatre is always helpful. So take a help from your colleague nearby. Thank you, Dr. Osman. Thank you. So we can move to the next session now.
Thank you, Dr. Osman, for such a nice and elaborative presentation on a topic, or I must say the difficulties which everyone in this house must have encountered while doing surgeries on gallbladder. And thank you, Dr. Tohar and Dr. Sachin, for chairing the session.